So I'd like to introduce Dr. Sandra Staffieri, who's a clinical and research orthoptist with several decades of experience in clinical paediatric ophthalmology, paediatric eye cancer and genetic eye disease research, a research fellow at the Centre for Eye Research Australia, principal or associate investigator of numerous research studies, including lines around LHON. As a clinical researcher, Dr. Staffieri is not only interested in developing and implementing strategies that promote early diagnosis of eye disease, but also in understanding how the patient or the caregiver's lived experience can inform changes to clinical practice. And when we talk to Dr. Staffieri about today's topic, what's really interesting in the research is the focus on the patient and their voice. And I'm really interested to hear what you've got to say today. Welcome.
Thanks very much for the introduction. Thanks to the Mito Summit today. And to be honest, I could actually talk about this for hours. However, I know I need to keep to time, so I hope you'll excuse me for referring to my notes. And I'd also like to mention that, as Claire said, that although vision loss is a common symptom across multiple types of Mito conditions, I'm going to be focusing on one type, Leber Hereditary Optic Neuropathy. However, as you'll see in the second part of my presentation in particular, I truly believe our research findings and even our research methods could apply to any Mito disease, but we'll get to that a little bit later. Okay, there we go. So as a guide to my presentation this morning, I'll be outlining what Leber Hereditary Optic Neuropathy is, a little bit of background of what qualitative research methods are, and that's so that you can understand the overview that I'm going to present of our current research project. And then, as I said, I'm excited to give you a sneak peek of what our findings are going to be. So, Leber Hereditary Optic Neuropathy, you will have heard it mentioned as LHON or LHON. It comes across many different names, and it's been quite interesting to see how AI transcription technology is coming up with all sorts of other names like LHON and LHON. But that's what we talk about. That's the acronym that we often use, and we'll split between LHON and LHON throughout. So it's an eye condition that is caused by a number of different genetic changes in the mitochondria. And as a mitochondrial disease, as you know, it is inherited along the maternal line. So a woman's sons cannot pass it on to their children, but all her daughters will. And also, not everyone with the gene change will develop the eye disease, and some will develop other non-ocular problems, such as those who have LHON+. And there are three very common mitochondrial changes in Australian families, and they are the 11778, 14484 and 3460, although in some families they may have actually more than one of those gene changes. So the main characteristic of LHON is that it presents a sudden painless loss of vision that can start in one eye and progress within weeks or months, although the pattern and interval between people who are affected with LHON is not the same. It may start with blurred vision, which may not be readily noticeable until it's quite advanced, or once the other eye begins to be affected as well. And the initial vision loss is most noticeable when they're reading, trying to look at someone's face, driving, and even putting on makeup. Typically, LHON-related vision loss usually begins in a person's teens or 20s, but it can definitely occur in early childhood and later in adulthood. And as you know, males are affected more frequently than females, and there is no known definitive cure for LHON, although this is the subject of lots of research beyond the scope of my presentation today. That said, some people may in fact recover some vision with no treatment at all. And to understand how the eye may look different when a person has lost vision from LHON, we need to first understand what a healthy eye looks like. So when we look inside the eye, we can see the retina, which is the light-sensing tissue that enables us to see. And the macula is this bit here in the centre, and the fovea, and this is where our best and sharpest vision and our colour vision occurs. And this is the optic nerve, and you can see the blood vessels coming out of that sort of oval-shaped part of the eye. And those blood vessels spread out across the retina, bringing oxygen and nutrients to the retinal cells. And the optic nerve should be this nice, healthy, fleshy pink colour. In LHON, however, you can see that the optic nerve has quite a swollen appearance, which then progresses to becoming very pale. Now, this is what a visual field test result looks like. And it measures how well you see, not just in front of you, but around you as well. And if you've had this test, you might recall being asked to look at a central target and press a little button when you see a small light appearing with that sort of is often as a varying intensity, and it'll be all over the bowl that your head's sitting in, and sometimes it's in the centre. And of course, we test each eye separately. And because LHON affects the optic nerve, it will have a significant impact on how an affected person can see around them as well as in front of them. And this is why testing the visual field is such an important assessment. Shown here is the visual field test on the left eye for someone with no eye disease. The small black spot is their optic nerve, and it looks black because there's no retina there to perceive any light. It's just a bundle of nerves exiting the eye like a telephone cable. And as different nerve fibres are affected in LHON, different parts of one's visual field become affected. Now, for someone with LHON, the visual field can change quite dramatically over time. First, the blind spot may appear a little bit enlarged, the top right-hand corner, where it's all black. And that may not be apparent to the person that it's happening to at that time. What becomes apparent is when they start to lose their central vision, and that is very noticeable. And then it extends further out, causing extensive visual field loss from the centre of their vision all the way out to the periphery. And for most affected people, the vision loss is permanent, and it marks a permanent and significant change to their life as they knew it. Now, building on Professor David Mackey's more than 30 years of work on LHON at the time, in 2021, our team, myself, Isabel, and Lisa Kearns, we published a revised risk of losing vision if you carried a LHON genetic change. Across every one of our 96 pedigrees or family trees for Australia and New Zealand, we counted the people with or with a family history of LHON. We counted all the males and the females across multiple generations, where some pedigrees had over 1,000 people in them. And we calculated that 355 people at that time were probably living with LHON-related vision loss, and the risk of losing vision was actually 17.5% for males and 5.4% for females. And this is significantly less than the often quoted risk of 50% for males and 10% for females. And whilst this study has been really invaluable when it comes to counselling patients and their at-risk family members, it provides a view of LHON reduced to a numerical value. How many people went blind and what was the risk for everyone else? It's really important information, but that is not the full long story. So this brings us to one of our current research projects, and to understand this project, I would just like to explain the difference between quantitative and qualitative research methods. Now, deciding which research method you choose depends on what you actually want to find out. Quantitative research is about counting, whilst qualitative research is about understanding experiences. Now, this cartoon shows in one frame someone who's selling ice cream, and there's another person hiding who's counting how many people take up the offer of free ice cream. That's quantitative. Whilst qualitative approach might look at what do the people who take the free ice cream think about getting the free ice cream, how did the free ice cream make them feel? So that's the difference there. Now, there are quite specific characteristics that distinguish between these two research methods, particularly relating to what we actually want to find out, how we collect our data, how we analyse it, and then how we report it. And most often, interviews or focus groups are used in qualitative research. And this is so we can explore people's experiences or beliefs, and the analysis does not involve statistics, mathematical programs, or graphs, which are not my forte. But rather, it's looking at what people are saying and whether different people have the same or opposing experience. And so when it comes to understanding a person's experience or a patient, one of the first skills a health professional learns during their training is to take a medical history, which will guide the examination of their patient and help them decide what other tests do they need to do so they can come up with a diagnosis and management plan. We don't necessarily record everything that a patient says, though. We may not even ask all the right questions, but if we have this general conversation with a patient, we may not write down all the other things that they're telling us because it doesn't necessarily in our sort of, I guess, medical framework match what we actually want to know. But in fact, there is great richness in what our patients tell us. We just need to listen. And it's this wanting to know more about a patient's experience that led me down the path of qualitative research, not just that there's no maths. I started dabbling in this research method during my PhD when I learned about qualitative research methods. And since then, I've been really fortunate to work with a number of researchers to understand what we call their lived experience. And they took me on the journey with them to understand childhood glaucoma, which is raised eye pressure and it's a blinding disease, and retinoblastoma, a childhood eye cancer, which is blinding and can be fatal, through the eyes of the people who have the disease or their family who go through that experience with them. Now, some years ago, my great friend and colleague, Lisa Kearns, was on maternity leave. So it was now me on the other end of the telephone fielding the calls of people who had been newly diagnosed with LHON, or it was their family member. And what I heard was not a number, but an individual's experience. Not only that, I heard the same experiences being said over and over again: delayed diagnosis, challenges with sudden vision loss, and the impact on other members of their family. Incidentally, what they talked about really resonated with me during my qualitative research for childhood glaucoma and retinoblastoma. It doesn't matter what the condition is, everyone seems to say the same thing. And I couldn't do anything with the stories I heard over the telephone, but as a clinician researcher with qualitative research experience, I knew how I could get this information as evidence that we could then use to advocate for change. This time I wanted to know not how many people had lost vision, not how many people might lose vision, and not whether their vision improved or not, but what was it actually like? What was their experience? And what could we, in particular as clinicians, do better? And so, with a very generous funding from the Mito Foundation, the LHON lived experience study was born, and I assembled a team of experts, qualitative research methods, and lived experience of vision loss to help me. We wanted to understand LHON through the eyes of the LHON community, those who had lost vision, those who might lose vision, the mothers who were carriers, as well as their caregivers or partners. And we designed this study in 3 phases. In phase 1, we held focus groups with representatives from each of those groups of the community. Together, we established an interview guide. What could I ask? What should I ask? And how should I ask it? And this was a challenging process as these participants were eager to share their stories. And we knew that it was their story that underpinned their suggestions or justifications for the questions that they wanted included. So I was really excited for the interview stage that was coming up. And finally, it took a long time, but with all the research ethics committee approvals in place, we started phase 2 at the end of September, and this was the in-depth interviews. And we completed 25 interviews so far, but more about that later. As I mentioned earlier, once all the interviews are transcribed word for word, they'll be analysed to identify those common and recurring themes and sub-themes. And this is an iterative process and takes a very long time. There is no computer to do it for you, although AI software can help speed up the process of the transcribing. Thankfully, though, there is software like NVivo that helps me sort all of those codes and narrow them down to just a handful. And in phase 3, we'll generate a survey with those main themes and sub-themes that I establish in phase 2, and we'll circulate that survey more broadly to the LHON community. It doesn't have to just be in Australia or New Zealand, just to see what the generalisability of our findings might be. Now, although phase 2 is still in progress, I'm really excited to share some of the preliminary results with you. And even though I've not formally gone through the intense process of coding, it's really clear just listening to these stories that there are very strong and recurring themes emerging. And I'm sure as I go through some of these preliminary findings, many of you with experience of Mito may relate to some of these themes. And I firmly believe that much of what I'm finding out is not unique to LHON, but it's unique to Mito in general. So to date, I've got 37 people who've consented to the study, and I can go up to 60. And as I said, 25 interviews have been completed already across all the groups within the LHON community, affected, unaffected, mothers and caregivers or partners. And as I said earlier, most interviews have taken about 90 minutes, and I've recorded 35 hours of interviews so far. The interviews start with an open question where the participant is asked to describe their diagnostic journey, and they all have incredible stories to tell. Delayed diagnosis, you won't be surprised, features every single time, often being disbelieved. Participants recalled being sent to psychiatrists or psychologists, or the diagnosis was discounted due to the health professional's belief that females or children can't lose their vision from LHON. No one knew anything. They thought I was putting it on. Oh, you don't have LHON like your brother. You're a female and females don't get it. Information can be inaccurate, or they are directed to the internet, which may or may not be trustworthy. They said to me, just go to the internet, but how do I know what to believe? Grief. There's a lot about grief. You have lost your future. The moment they realise their vision had disappeared or their diagnosis was confirmed is seared in their memory, realising their life as they knew it had completely changed. I remember the day, I remember the moment, and my world came crashing down. The impact of vision loss is always one of initial despair. Suddenly my life changed. We were imprisoned overnight. But for some, the impact of vision loss could eventually become one of hope by developing a life-affirming perspective and an acceptance after a long time of adjustment. I wouldn't be who I am today. My whole world opened up in a different sphere. Their sense of self changes. I lost myself. It has been important to participants to not be defined by the condition or disability. It's not who I am, it's something that happened to me. I'm not disabled, I'm differently able. One's self-esteem is eroded with the vision loss, being treated like a child or being spoken to in a way that shows that person does not understand that for them, vision loss is just a vision loss. It hasn't affected how they hear or how they think, except people with non-cluster conversation. I am not deaf or dumb, I just can't see. And the theme of the visibility of their disability has been prominent but also quite varied. With LHON, the person's eyes appear perfectly normal and their vision impairment is not obvious, and many like it just like that. And they prefer not to be seen as a blind person. No one knows how blind you are until you tell them. But then again, some do want to advertise their vision loss because they're proud of it. I want my white cane in the photo. And this plays into their identity of being seen as a vision impaired person or a person with a vision impairment. I'm not a blind car enthusiast. I'm a car enthusiast. There was fear of developing vision loss, like their family members. It's like carrying a grenade and not knowing if it's ever going to go off. But others felt there was no point in worrying about it, as it was seen as being out of their control. Why worry? There's nothing I can do to stop it happening anyway. Maternal guilt is all pervasive, and no amount of their child's reassurance will change their feelings. I know they don't blame me, but that doesn't stop the guilt. It's also clear vision loss and the subsequent diagnosis impacts everyone within the family. It was like the rug was pulled out from under her. It pulled the rug out from under all of us. But for some, there has been a positive impact, and it brought the family closer together. Access to support has been varied. Family were always mentioned as being supportive, but there is a desire for a comprehensive team of professionals, information packs and resources to help the affected person and their family adjust and adapt to their vision loss and how to navigate their new world. Where is your crack team to help me? It will be no surprise everyone's mental health is impacted, vision impaired or not, due to the subsequent loneliness and isolation, but the perception that the only person with mental health impacts would be the one who lost their vision or who is affected, and that there was no funded support for their family. There's no NDIS funding. There's NDIS funding for him, but not for anyone else. Although recognising the need for counselling could be helpful, their experiences were largely negative. They described a lack of understanding on the part of the counsellor. They had no idea what I am going through. It was unaffordable, and that in the end, no amount of counselling changed the fact they were still blind. As a health professional myself, some participants' experiences with health professionals has been at times embarrassing and difficult for me to listen to. Insensitivity in delivering news. Good news, we have a diagnosis. Or a health professional not thinking about what the implications of the vision loss were. I was given a pamphlet to read. He just told me I was blind. This is exemplified by the experience that resonated with me and my understanding of what it is to have vision loss. You need a little background though. My grandfather was blind. I only knew him as a blind person. So I thought I knew what it was like to be blind, to understand a blind person living with complete total vision loss. And I could always recall him gently moving his hands across the dinner table at mealtimes, feeling his plate, feeling where his knife and fork was, his napkin, his perfume has to be there, a glass of wine. And that was my memory. And then when I did the first interview, my participant came and did that in person at the Centre for Eye Research Australia. And I watched him as he sat in that interview room with me. He did exactly what my grandfather did, throwing his hands over the table, gently touching everything. He's touching the padded walls, which was it's like soundproofing. And he was touching it really, really gently. And I thought, wow, I haven't thought about that, but however long my grandfather had passed away, probably 40 years. And he really reminded me of my grandfather. So when a woman I interviewed described being scolded by a nurse for touching the back of her hand to see whether the needle for her drip had been removed or not, she replied to the nurse, "You just don't understand. My fingers are my eyes." I had never thought of that. I knew what he was doing, but I had never thought of it in that way. You would not get that perspective of vision loss from taking a medical history or getting someone to complete a survey. Every research project I do, I learn you don't know what you don't know. And a participant thanked me at the end of their interview just this week. And they said, there is loneliness in your experience. It's great to have your voice heard. And I'm really, really privileged to be in this position of listening to their voices and giving the LHON community, the Mito community, a voice. I really look forward to finishing this project. It can't happen fast enough and bringing the findings more formally to life, where I hope and I'm sure they will be the catalyst for change. In closing, I'd like to acknowledge David Mackey and Lisa Kearns, who brought me into the world of LHON, and my co-investigator Joanne Mosen, for coming on this research journey with us. I'm incredibly grateful to the research participants for their time, their honesty, and their vulnerability. Of course, none of this work could be done without the generous support of the Mito Foundation, who share our visions. We're still enrolling people from within the LHON community to participate in interviews. So if you are interested in participating, just send me an email. It's on the screen there, or get in touch with Claire or Tony, and I'll be happy to get in touch with you. Thank you.